The topic of this case presentation is the use of solitaire stent, which is basically a neuro stent in case of the peripheral vascular disease. For the first time, the solitaire stent has been used as a bridging technique in case of peripheral vascular disease. This is an old postmenopausal lady presented with a sudden onset of pain in her right leg. There was no history of claudication, and there was a numbness and blues discoloration in the right leg. She was a known case of diabetic and hypertension and bronchial asthma. On admission, she was restless and breathless. However, the oxygen saturation was normal. On examination, the foot were not moving, and there was no clear line of demarcation. However, there was a swelling in her right foot, and there was no sensory sensation in her right foot. Her ECG was done, which showed changes of left bundle branch block, and 2D echo was reported as a global hypokinesia. There was no clot in heart chamber, and the arterial blood gas showed metabolic acidosis. The CT angio was performed because of the pain and the pain in the right leg, which showed there was the common aorta was normal. The superficial femoral artery was normal. However, there were multiple intraluminal filling defects in the distal part of the superficial femoral artery and the sudden occlusion of the distal segment of superficial femoral artery. The popliteal artery was completely occluded, and there were the anterior tibial artery was partly reforming. Thus, the clinical diagnosis of non-viable extremity was formed. Now, the vascular surgeon opinions was taken, but he said that no intervention should be done as of now because there is no line of demarcation, and ultimately the patient would require above-knee amputation. But there was discussion among the relatives and the other doctors, and we decided to attempt to revascularize the lower limb so as to decrease the level of amputation. So the patient was referred to cath lab, where we did the angiography, and the conventional angiography revealed the multiple filling defects in the profunda femoral artery, and there was a superficial femoral artery also showed multiple intraluminal filling defects. The popliteal artery showed multiple defects, and there was partial deformation on the anterior tibial artery. So in order to decrease the load of clots, I thought I should do the mechanical thrombectomy. I had used this solitaire stent in case of the stroke, acute stroke, and the same stent I attempted to retrieve the multiple clots. So I went ahead with the guiding catheter in the proximal superficial femoral artery, placed the solitaire stent in the popliteal artery. This is a distal marker, and up to here is a stent. And the stent was completely removed, then reintroduced. I repeated this step 6 times, and I was able to remove the clots. You can see the clots over here, which are entrapped in the solitaire stent. This is just a correlation. This is the thrombus in the middle cerebral artery. There is a stent lying within the clot, and same type in the peripheral vascular disease. When you retrieve the stent, the thrombus, which is entrapped in the solitaire stent, get also pulled along with the stent. So this is the picture which is post-mechanical thrombectomy. You can see the clots were removed in the superficial femoral artery. Now they're clearly showing the stenosis in the mid part of superficial femoral artery. So thereafter, the balloon angioplasty was performed. Now this is a post-balloon angioplasty showing the good caliber. However, the balloon angioplasty did not work in the distal part of the popliteal artery. So I placed a Fontaine system for the thrombolysis. This is a Fontaine system which is lying in the distal part of the popliteal artery and part of it lying into the anterior tibial artery. I introduced 2 units of LT-pace as a bolus. Thereafter, 1 unit of LT-pace for the next 24 hours. Similarly, the patient was simultaneously put on the antiplatelet through the IV line. Post-treatment, you can see there was a good recanalization of the superficial as well as the popliteal artery, and also the tibioperineal trunk. And the good reformation also of the distal part. The common peroneal artery was completely reformed, anterior tibial artery was completely reformed, the posterior tibial artery was formed in the proximal as well as the distal part. Over the next 6 days, the patient was in ICU. She was feeling much better. The patient's pain in leg had completely disappeared. The skin temperature had become from cold to normal. She had a moderate renal function. The creatinine remained 1.4 with a urine output of 1.2 liters per day, and the serial CPK levels were decreasing. So the patient was better. Now, after 6 days, the line of demarcation got appeared in the midfoot. So we were able to decrease the level of amputation from above knee to midfoot. Because of the financial reasons, patient got discharged and shifted to another hospital. So the conclusion is, the solitary stent, which is a basically neuro stent, which can be used for the acute stroke, can also be used in case of acute peripheral vascular disease, but however, because of the limitation in the size of the stent, it requires introduction of the multiple stents. And finally, the intracranial thrombectomy with the solitary stent was an incidental success, neither planned nor anticipated during the development of the disease, and now is being used successfully. And maybe this case report describing use of solitary stent in the peripheral artery acts as an ignition spark for the new developments. Thank you.
Thank you. I enjoy your presentation, and I would like to involve Dr. Khanna in the discussion. What is the current availability of this device? And Dr. Khanna, do you have the experience with such a problem?
Yeah, I must congratulate you for a good case. Normally this device is available to our neuroradiologist, and they do it for the intracranial thrombus. But I was thinking, it would have been like what we do in such cases is just pass in a hydrophilic catheter and suck out the clot. But the acute thrombus usually can be sucked out by just a thrombosuction. And then we just pass in Cartesian wires or a small microcatheters and infuse urokinase. That works many times. Maybe Michel has experience.
Michel, a comment, and Ashwin, you will answer.
I don't have any experience with your device. No, when I have thrombosis like that, thromboaspirate or mechanical devices like this, something like that, but I don't have any experience with that.
So to answer Dr. Khanna's, this was a diagnosis of subacute thrombosis. It was not a hyperacute or acute thrombosis. Initially, I placed a catheter in the thrombus, I was not able to retrieve or aspirate the clot. It was a chronic, like a heart thrombus. When I attempted with a stent, with the clot which is entrapped in the solitary stent, you can just feel it's like a calcium. It's not a smooth clot. So it was not able to aspirate with the...
Thank you, Ashwin. We have to go on.
Thanks.
We have to go on.
Thank you, sir.
We are very late.